All right, everyone, you're almost done with me. We've got this chapter to do, and then I'll probably send out some review videos. So let's get started. All right, we are doing reproductive system. And once again, I have a crazy cat in here, so bear with me. All right. Let me bring up the, there it is. Hey, all right, let's do this. We are talking about the male and female reproductive system. We'll just briefly scrape the surface of fertilization, implantation, and embryo development. Talk a lot about hormones in here. I don't really talk a lot about the functions of the reproductive hormones until we get here, even though they come up in several chapters before this. So we'll talk more in depth about what the hormones do for reproductive system. All right, so this is a crazy picture of an ovum being bombarded by sperm, but there is only one sperm that is going to get the gold medal and to be able to penetrate the egg. Once the egg is penetrated by the first sperm, no other sperm can penetrate it. The ovum, the cell wall changes a little bit so that there is not more than one fertilization. All right, so we're going to start with just talking about the purpose. And we're continuing the human species here by reproduction, the production of progeny. We do this with gonads. Gonads are the reproductive organs of the male and female. Both males and females have gonads. I know the guys talk about their nads more than the girls, okay? But we have ours. We just put them on the inside. All right, so testes are going to be the gonads of the guys. The ovaries are going to be the gonads of the females. And the reason why these are the primary reproductive organs is because they produce gametes. Gametes are the sperm or the egg. Okay, so here's the male gamete, here's the female gamete, sperm, spermatozoa, ovum, or egg. Okay, and then when timed appropriately, we get the sperm that is going to penetrate the egg. Both cells are going to contribute their genetic material, and that will provide you with the first cell of a brand new individual. Okay, we are going to depend on meiotic divisions, which we haven't talked about yet. And so we have adult male, testes, ovaries. We get the sperm with a haploid number of chromosomes. Remember, haploid is half the amount of a body cell. So 23 for humans. It's going to be different for other species. And then fertilization takes us back to diploid, 46. And the zygote is a fertilized egg. Okay, so zygote is one of the bullet points on your review sheet talking about what is a zygote. And so the definition would be a fertilized egg. Is it haploid or diploid? It is diploid because the sperm and the ovum both contributed their 23 chromosomes. All right, the testes are going to provide androgens. All right, androgens. And as we will see, they provide a little bit of estradiol, which are some estrogens as well. So we'll look at that in a minute. The ovaries, their main two hormones are going to be estrogens and progesterones. All of these are going to be steroids, okay? They're all going to be steroid hormones. And then the adrenal cortex, we also know, we've studied this already, are going to produce some testosterone. In fact, after puberty, this is the only place that females get their androgens from, is going to be from the adrenal cortex. Okay, so we look at what these hormones do, and this gives you a list of all of the major functions of each of these. The important ones are going to be spermatogenesis, making of sperm. So testosterone is heavily involved in that. And estrogen is going to be heavily involved in folliculogenesis, which just means the maturation of the egg within the follicle cells that it lives in. Male secondary sex characteristics, testosterone is highly important for that. Without it, you may not be fertile, you may be sterile without the testosterone. So the penis and scrotum growth, facial hair growth, and that's going to be armpit and pubic hair growth as well. And then the larynx elongates, lowering the voice. And this is why during puberty you get some cracking because you don't have a lot of control over it. Shoulders broaden. You get muscle increase, bone increase. So lengthening of bones is going to be big. That's not here, but lengthening of bones is important because that will continue to allow men to grow all the way up until that 25th year, right before we start dying. And females don't have that because they have very, very little testosterone. In fact, their estrogen is actually going to close off their growth plates. And so we stop growing faster than males. All right, for females, estrogen gives us our secondary sex characteristics, girls, breast development and maturation of the mammary glands, hips broaden, so fun, and pubic hair growth. And in all of this, we also have what's happening in the ovaries and in the testes as well. All right, testosterone, a little bit more information on the effects on males. Sex determination, when testosterone is secreted, this occurs during embryonic development. Embryonic development will determine the sex of the embryo. And this comes from developmental ducts that are different, when we are born. And this is going to contribute to the growth of all of our ducts, all of our glands, and the male external genitalia for male sex determination before birth. Spermatogenesis is going to be at puberty, which is about 14 years of age, and that is going to complete the meiotic division of the sperm, and then after puberty, maintenance of spermatogenesis, which is a lifelong process. Secondary sex characteristics we already talked about. And then anabolic effects. This means ana means up, and so we are building up tissue, protein synthesis, muscle growth, growth of bones, there it is, growth of other organs, and red blood cell formation. And this is why males have a higher hematocrit or percentage of red blood cells than females, because testosterone supports that, and we don't have a lot of testosterone. However, males also have important functions of estrogen. Estrogen is going to be secreted by the testes, and estradiol is just a type of estrogen. And the sustenacular cells, which we'll talk about, interstitial cells, and developing sperm are all going to secrete small amounts of estrogen, not high amounts. And then the receptors are going to be on the same cells, sustenacular, interstitial, and then cells lining the ducts and accessory glands. All right, so what is it going to do for us? Well, spermatogenesis, because the sustenacular cells and interstitial cells are going to be triggered to support sperm production, and then regulating the environment of the developing sperm, fluid reabsorption, and then sealing off of those epiphyseal plates. So you guys finally will stop growing. But there are more over here, and I want you to know these because this is one of your bullet points, I believe. Describe the role of testosterone versus estrogen in males. So we already just did testosterone. Now let's do the estrogen, erectile function, and spermatogenesis. All right, and so if we have, if erectile function is going to have to do with vasodilation of vessels so that blood flow can erect the penis. Bone health, okay? Well, that's the same in females. Estrogen supports bone health. And because we as females lose that estrogen after menopause, it decreases our bone health. Regulation of fat mass and lean mass. brain functions. We don't have to get detailed about any of those, lipid metabolism, and skin health. So all of these are going to be important in males as well as in females. All right, hormone effects on males. Now, what triggers the effects of these hormones to be secreted even? And we saw this when we looked at the endocrine system. We saw that the hypothalamus is going to be the master gland that kind of is in charge of a lot of cascades that occur in the body. And this is no different. So we have the hypothalamus that is secreting GnRH, which is gonadotropin releasing hormone, if you remember the term releasing, right? And that is going to stimulate the anterior pituitary to release gonadotropins. And those two gonadotropins are going to be FSH and LH. So what is the function of FSH? It stands for follicle stimulating hormone. It is going to go to the testes, specifically the seminiferous tubules where sperm are produced, and it is going to trigger spermatogenesis. Spermatogenesis, or the making of sperm. When sperm count is normal, and we have gotten to our 500 million, which is how many you guys make every single day, 500 million sperm, then the seminiferous tubules will secrete inhibin, and it is going to inhibit the secretion of FSH and say, okay, we're good. We've got all of our boys and they are doing good. So let's turn off the FSH. So this is a negative feedback process that allows sperm production, spermatogenesis. Now, LH, luteinizing hormone, is very important in males because it is going to stimulate the interstitial cells. And what do the interstitial cells do? They secrete testosterone, and testosterone is necessary for sperm production as well and maturation. Now, when we have lots of testosterone that is made, it is also negative feedback where it will go and it will say, hey, I've got plenty of testosterone, turn off the LH. Hey, I've got plenty of testosterone, let's turn off the gonadotropin releasing hormone, okay? So both of these being negative feedback processes, but it regulates what's going on in the testes. All right, so let's look a little bit more closely at what's going on here. We've got the anterior pituitary, and here we have again, FSH and LH. LH is going to be triggering testosterone secretion. There we go, testosterone secretion from those interstitial cells. And the testosterone goes to the seminiferous tubules and says, hey, let's trigger the maturation of sperm, okay? And so you can see that the seminiferous tubules are triggered for spermatogenesis, and also the seminiferous tubules are going to release other androgens and estrogens. So here's that estrogen. Then we have inhibin that is secreted as well, and we talked about that over here. We've got FSH, which is triggering similar things, and so you kind of have this whole cycle where everything is really supporting spermatogenesis. All right, male structures. We've got the primary reproductive organs. The reason why the testes are primary is because they make the sperm, and everything else is accessory. So 1 through 4 is the duct pathway that sperm will travel from the testes to the epididymis, to the ductus deferens, to the ejaculatory duct, and through the urethra, okay? 5 through 7 are going to be the glands that secrete seminal fluid, okay? So those are our glands. So these are all accessory reproductive ducts and glands. Then we have the external genitalia, and that's going to be the penis and the scrotum holds the testes. Why do we need reproductive systems? They are not vital for living. We can do without them. However, it is going to maintain the human race. And we do that by producing the hormones that are the communicators for this. We've talked about the reason why we need testosterone, production of male gametes, spermatogenesis, sperm production, and then production of semen. Without proper semen, the sperm cannot do their jobs. There are ingredients that are in the semen that allow ejaculation, first of all, and second of all, it allows the sperm to become motile, swimmers, It doesn't allow them to do that too early so that they maintain the energy that they need for the moment that they need to have that energy. And then copulation, none of this can happen unless we can have sexual intercourse. Copulation is a word that is commonly used on Animal Planet for animals, but it is a scientific word that means intercourse, making love, having sex, banging it out, whatever you want to call it. Okay. Scrotum, the function. This is the home of the testes. And we include this in here because the scrotum allows the testes to be protected, especially against temperature changes. Okay. Now, why are these testes outside the body? Because we all know that they're vulnerable and that to be hit is very painful. There's a lot of nerve endings in there. So why don't we have them inside, nicely tucked away, in order for them to be safe? And the answer is because it's too hot inside the body and the sperm cannot survive at core body temperature. They need to be 2 degrees lower than core body temperature. Okay, so there's a few structures in the scrotum and on the testes that are going to help to maintain this 2-degree colder temperature. All right, first we have this pampiniform plexus. This is a vein network in the spermatic cord. So this whole region that I'm circling is the spermatic cord, and that prevents warm arterial blood from overheating the testes. And so it allows a less warm blood to be around the testes. The dartos muscle is going to be in the wall of the scrotum, and it is smooth muscle, non-voluntary, that wrinkles the scrotal skin if it gets too cold, right? And so it is going to pull the scrotum, wrinkle it up and pull it closer to the core of the body so that the testes can be warmer. However, if it is too hot, then the dartos muscle relaxes and the scrotal skin becomes flaccid, and you have more surface area for heat to radiate off. So that's the dartos muscle. Then you have the cremaster muscle, and that cremaster muscle surrounds the entire testes, and it is skeletal muscle, which means, you guys, you have control over the cremaster muscle, or you should. And so, but a lot of this muscle is going to be reflexively contracting. So due to sexual arousal or temperature change, this muscle will bring the testes closer to the body or relax and be loose and flaccid so that it can release heat. All right, so upon reflexive stroking of the skin of the upper thigh, those of you who have had anatomy, you are familiar with the gracilis muscle that is right here, right, all the way down the leg. So that's why I call it the gracilis muscle. When you stroke the upper thigh, then that is going to trigger reflexive movement, reflexive contraction of that cremaster muscle. Okay, thanks, gracias. All right. So cold, testes are brought closer to the warmth of the body. Hot, it is loose and flaccid to release heat. All right, here's the testes. And in this diagram right here, we can see that there are little lobes, okay, little lobes, and those lobes each have seminiferous tubules. Seminiferous tubules are going to be the sperm factories of the testes, okay? 800 tightly coiled tubules in each lobule, and those are the seminiferous tubules. If you were able to see these in the lab, I don't know if they have free testes, but not free, like just in a bucket. You can cut these and you can actually take a little pin or a needle and you can actually pull out the seminiferous tubules and see them. They're like thinner than a piece of thread. They're pretty thin, but you can still see them. Sperm pathway through the testes. We're going to start in the seminiferous tubules. Half a mile there, okay, half a mile. And then we're going to send those sperm go into the lumen and through the rete testes. And then from the rete testes, we're going to send them to the efferent ductules. And so we'll see another diagram that shows us a little bit better. This is the spermatic cord. This is where the sperm will travel as they go farther through the pathway, because we're going to go from the seminiferous tubules, which are circled here, and then you have the rete testes, which is this network here. The efferent ductules aren't really well seen here, but they're like right here, efferent ductules. Then you have the epididymis. The epididymis, let's see, something like that. All right, epididymis. And then from the epididymis, you go into the ductus deferens, and the ductus deferens is going to be part of the spermatic cord that leaves the external genitalia and is going to then go through the inguinal ligament and into the pelvic cavity. All right, so let's look a little closer at the testes, because the testes are going to give rise to sperm. And these testes are not developing in the lumen, they're actually developing in the wall of the testes. So you can see this awesome diagram right here that shows the wall. And then the lumen is where they are released once they have reached a certain level of maturity. We start out with spermatogonium, spermatogenic cells, and spermatogenic cells are going to be the stem cells that give rise to sperm. They are found on the most superficial part of the wall of the seminiferous tubule. And then as they migrate, let's see, we'll go here, migrate and differentiate and divide and mature, then they become a more mature sperm that is released into the lumen. Surrounding these seminiferous tubules, we have interstitial cells. Your book still calls them Leydig cells, which is a really old name, and I haven't heard it in a while, so I was surprised they still had it. I like interstitial cells because inter is between the tubes in the interstitial space. This is going to be between the spaces of the seminiferous tubules, and these are the cells that make testosterone, okay? So they are endocrine cells right here, interstitial endocrine cells that make testosterone. This is one of your bullet points. Your bullet points say describe the following cells, include the function and what stimulates each: interstitial, sustanacular, follicle cells, zygote, and a gamete. All right, so we already talked about what stimulates the interstitial cells to secrete testosterone, and that was LH, okay, luteinizing hormone from the anterior pituitary. All right, we have sustanacular cells. These are also called Sertoli cells, which is what your book uses. Again, I haven't heard that in forever, but often you will see them called nurse cells as well. And that is because that is their job. They are nursing the developing sperm. Sustanacular cells, I like this name because it gives them sustenance. Sorry, my dog is, there's no one up there to tell her to be quiet, so sorry when she barks. All right, so sustanacular cells are going to surround the developing sperm, and they secrete an ideal medium for sperm division, growth, maturation. And what is in that medium? What is surrounding the sperm? We've got androgens, which is going to be our testosterone. So we have estrogens, which one of the jobs of estrogen was to be to support spermatogenesis and creating an environment that they could grow and develop in. We've got potassium, which is necessary for their growth, and amino acids. All of these are going to promote the division of spermatocytes. Another thing that the sustanacular cells will secrete is inhibin. And inhibin says, hey, we have developed enough, we're good for the day. And so that will go to the anterior pituitary to tell FSH to shut off. So we stop spermatogenesis. Okay, so sustanacular cells, what are they going to be? Here's the nurse cell. Here's the nurse cell right here. And that's going to be one of the nuclei of the nurse cell. And they are going to be stimulated by FSH. Okay. All right. So just some facts about spermatogenesis. Guys don't start producing sperm until age 14 after puberty, but it continues until age 70. 500 million sperm per day, which is why my husband tells me all the time, he's so tired. I'm so tired. Don't you know I'm making all that sperm every single day? So I wish I had never told him that, because now he uses it against me all the time. Complete maturation of sperm takes 64 days. And again, it starts in the outermost layer of the seminiferous tubule and works its way toward the lumen, where it is going to be released into the luminal fluid. The making of the sperm are going to be dependent on both mitosis and meiosis. So let's look at that. We have talked about mitosis already. In mitosis, the goal is to have the daughter cells look identical to the mother cell. All right, so here's the original cell, always diploid in mitosis, which means 46 chromosomes. You have mom that contributed 23. You have dad that contributed 23. Now, can these cells do with just one set of chromosomes? Usually they can, but the problem is that if you have a mutated allele, a mutated gene, well, that other 23, that other set of 23 is kind of your backup. And so it makes it so that we can function more effectively and without disorder and disease to have two sets, so we can always have a backup. It also allows genes to be expressed that are different than just having moms or just having dads, or we'd all be identical to one parent. This cell, when it divides by mitosis, is going to take that 46 chromosomes and it's going to replicate it. And so now we have two sets of 46. So when this cell separates, we get one cell with 46 and the other cell with 46, still diploid. And so we get two cells that look identical to the two daughter cells that are identical to the original cell, always with 46, okay? Meiosis only occurs in the gonads, right? You start out with a diploid cell. You start out with 46, right? You are going to divide by mitosis first, and we'll see that in a minute. And then you have two consecutive divisions, and those are meiotic divisions. And we have meiosis 1 and meiosis 2, okay? So this first one is going to be meiosis 1, and that is going to give us two daughter cells with two sets of 23 chromosomes. And then those are going to divide again in meiosis 2, and that gives us one set of 23. These cells are not identical to the original cell. They are going to go through a process of crossing over, which is going to allow these cells to have different genes and different expressions than the mother cell. And so we get in meiosis, we get 4 haploid cells, haploid meaning half the amount of chromosomes. All right, so now let's put that into play with spermatogenesis. All right, some of this we went through in anatomy, so let's cover it. We start out with mitosis. Mitosis, remember, always has 46. So we have our first mitotic division. Now, mitotic division, it's only showing one cell, but remember, we have two identical cells here. These two identical cells will be labeled A and B. A will stay a stem cell. So I like to say that the stem cell stays home to take care of the family business of maintaining the stem cells. B is going off to college to learn how to become a sperm. Okay, and you have this with all stem cells. All stem cells, you keep one at home, take care of the family business, and one goes off to college to become whatever differentiated cell it is going to become. And that is going to allow us to maintain a stem cell population. Okay, so then this cell right here becomes a primary spermatocyte. Primary spermatocyte is going to have 46 chromosomes, diploid, but it is going to divide through meiosis 1. Meiosis 1 is going to produce 2 haploid secondary spermatocytes. However, these haploid cells are going to be diploid in the fact, there's 2 sets, that we have 2 sets of 23, okay, 23 and 23. So we are going to have 46, but it's in 2 sets of 23. That becomes a secondary spermatocyte. The secondary spermatocyte is going to go through meiosis 2 division, and that is going to separate those 23 into 4 spermatids. Okay, so this is going to be called a spermatid when we finally get these 4 viable spermatids. Then the spermatids go through another process called spermiogenesis, and that is the production of sperm from the spermatid. So that is specific to the change from a spermatid to viable sperm. Okay, so down here you get that pathway right there and the numbers of chromosomes you have in each. All right, a sperm, you're going to have the genetic region of the sperm, and that means that's the head, and you have 23 chromosomes, so that's going to be right here. And you also have what is called an acrosome. The acrosome is a little helmet on the head of the sperm, but it's not to protect the sperm. It is loaded with digestive enzymes, and those digestive enzymes are capable, when activated, of digesting the wall of the egg. And so that is in a process called capacitation, which we talk about in just a minute, but I'll write it here. Capacitation gives the sperm the capacity to release those enzymes and to burrow through the wall of the egg cell. Okay. All right, so that's the acrosome. And then we have the middle piece, and the middle piece is going to be where all the mitochondria are for energy production. Because why do we need energy? Because of the third piece, we have flagellum, which is the locomotive region, and that is going to be the tail, which whips in this corkscrew motion in the surrounding fluids. And guys, you're the only ones who have a cell in all of human nature that has a flagellum. Okay, flagellum are pretty common like in bacteria, but this is the only cell in the human body that has it because they have places to go. All right, so those are the three pieces of the sperm. All right, spermatic ducts, we're going to go then to the epididymis, and the epididymis is going to be this tube that is going to leave the testes. It is on the posterior side of each of the testicles. So you have your seminiferous tubules, you have your rete testes, you've got your efferent ductules right here, and then you've got your epididymis, about 23 feet long, and you can store sperm in there for quite a while where they complete their maturation. Remember, it takes 64 days. Now, stored sperm can stay here in this epididymis for quite a while, and if they're not ejaculated and they get old, then they are going to be degraded by macrophages. Okay, all right, so that's the epididymis. And then we lead through the ductus deferens. So the ductus deferens was called the vas deferens for a long time, but vas means vessel, like a blood vessel. And this is not a blood vessel, it is a duct. So they changed the name to ductus deferens. However, the term vasectomy has stuck around. And the vasectomy is the procedure where they cut the ductus deferens as a birth control procedure. Okay, so 16 to 18 inches long. It has to go through the inguinal ligament, up, around, and over the bladder. And so it starts out in the external genitalia and ends up in the internal genitalia. All right, and it's loaded with smooth muscle, and waves of peristalsis are going to aid in peristalsis. This is the pathway that sperm is traveling during ejaculation. Again, you can store sperm here for a long time, and then it will become phagocytized. Okay, so the inguinal canal, again, is going to be where it has to pass through, and that inguinal canal can be a place of common hernias. And so, do I have a picture of that? Right here is the inguinal ligament that goes through the inguinal area, and then we have the inguinal canal right here. If that gets too large, either you can have intestinal tissue that pushes down into where the spermatic cord is, or you can have the testes that regresses back. That's less common, but it's pretty common in boys, especially younger boys who grow tall really fast. For no good reason at all. They just get a hernia because that tissue stretches out and opens up. And so that's why you guys go to the doctor and they tell you to cough, because coughing is bearing down, which pushes the abdominal cavity, puts pressure on the abdominal cavity. And if you have a hernia, then they will feel a bulge in that area where the intestinal tissue is pushing out. They tell you to turn your head so that you don't cough on them. Okay. Guys are not the only ones who can get a hernia. I think I mentioned last semester, I had a double inguinal hernia when I was pregnant with my son. And they said, hey, you have a double inguinal hernia. You have to get this fixed after you have the baby. And I was in so much pain, I couldn't even hardly walk. It hurt so bad. And the doctor said this, don't worry, as you get bigger, you will start to feel better. Now, how is that even possible? So let's look at that. All right, so here I am with this uterus that is growing a fetus inside me. And I've got this inguinal ligament that's going to be pushing through, it's hard to put a place on it right here. Okay. Pushing through. So I have these bulges and they hurt so bad. And so what's happening is, as the baby is growing, the intestines are actually under the uterus. Okay. And so as the uterus is growing, it pushes those intestines into that inguinal canal, and it's really painful. But as the baby gets bigger and bigger and bigger, this uterus is huge and it comes forward where all the intestines are now behind it. And so at about 7.5 months, all of a sudden, all my pain went away. I couldn't even believe it. So here I am, huge with this baby and no pain. So 7.5 to 9 months were the best months of that pregnancy. And then after 6 weeks after I had the baby, they did a little laparoscopic surgery and put mesh in there and closed him up. All right, so let's now talk about vasectomy. Okay, vasectomy is a procedure where they cut the vas deferens. So the procedure is going to be where the doctor goes and starts to palpate or feel for the spermatic cord. And they take a kind of a dull instrument, and they take it and they stab it right in between the testes and make a hole in the scrotum. That scared my husband a little bit. I will have to, well, it scared me. I was watching my husband get his done. I said, I'll go with you, honey. And he was like, I know you don't care about me. You just want to watch. And I'm like, I kind of do want to watch. So the doctor showed me the whole procedure. It was kind of cool. So there was a puncture that was made. The reason why they puncture it and not use a scalpel is because the scrotal tissue will curl up on itself with a puncture, and it will heal on its own without any stitches. So it heals a lot faster and a lot better. So that's why they do the puncture method. Then he sticks a little hook in there, and it looks like literally like a crocheting hook. All right. And they stick it in there, and they're scooping around, trying to find the ductus deferens within the spermatic cord. So they do so. And when they do, they pull it out. So you can see how it's being pulled out right there, but it doesn't just look like this when it's pulled out. It is loaded with connective tissue all the way around it. So they take a little scalpel and very, very carefully and artfully, I will have to say, maybe because I was there, very carefully move all of the connective tissue away until they get the ductus deferens. When they do, they put it in a loop like this, they cut it, and then they cauterize it. And that cauterization is going to seal it off. And then they put clamps on it. So there's little metal clamps that are on it. And when all three of those procedures are done, then they shake the scrotum, and the ductus deferens falls right back into place. And then they go to the other side and do it to the other side. Now, remember that we can have sperm in here for several months. So after this procedure was done, was I safe? Are we like, we're good to go, birth control? And the answer is no. There has to be a certain number of ejaculations, and I think it's 40 ejaculations after the procedure is done to try and clean out the ductus deferens of all hiding sperm. I remember the doctor said, the walls of the ductus deferens are like the shores of Lake Powell, where you have so many canyons and crevices and cracks and lots of places for you to park that boat where you can hide and be away from everyone. And that's what the sperm do. And so they are, even after 3 months, when my husband went to go check for sperm viability, there were still sperm in the ductus deferens after 3 months. So it was kind of crazy. So 6 months, I think, is the safe where it will be, they will be phagocytized after that time. All right, spermatic, the ejaculatory duct is the next place we go. So we went, and now we are going to the ejaculatory duct, which is right here, and that's about 1 inch long, and it empties into the urethra, which the seminal glands also empty into the urethra. The urethra is not part of the duct system because it is not secreting anything. It's just a pathway. And so we've got one, the prostatic urethra, 2, the membranous urethra, and 3, the spongy urethra. And that urethra conveys both urine and semen, but at different times, thank goodness. But that is going to be different than the female reproductive system, which is going to have 2 separate pathways. All right, so let's go to quickly our seminal glands. Now, seminal glands, when we're talking about physiology, what is in the secretion of the semen and what is the purpose of each secretion? Okay, so I believe that you have, okay, so let me make sure I've covered all this. We described the results of mitosis and meiosis and spermatogenesis, but we still need to talk about it in oogenesis. We describe the role of testosterone versus estrogen in males. We describe what protects the testes from body heat. We described interstitial cells, testinacular cells. We still need to discuss follicle cells. We determined that the zygote was a fertilized egg, and we determined that a gamete is either the egg or the sperm. And we talked briefly about what capacitation was, is the ability for the sperm to become 1, mobile, and 2, where they have those enzymes that are released in the acrosome to allow them to penetrate the egg. Okay, all right, so fructose. Fructose provides an energy source for sperm because remember, they have a long way to go and they need to make energy in the mitochondria, so fructose is used for that. Prostaglandins is going to stimulate smooth muscle during the ejaculation. And then also there are other prostaglandins that thins out the vaginal mucus that blocks the cervix so that the sperm can get through. Fibrinogen is going to form this temporary clot, and the clot is going to be there to keep sperm in check until they are in the perfect position to be able to swim toward the egg. Prostate gland, 20 to 30%. Seminal plasmin, this is an antimicrobial, which is a reason why guys are less likely to get urinary tract infections, as well as the longer urethra. And then profibrinolysin is going to break down that clot, the coagulum formed after ejaculation, and when the sperm are ready to swim away. What movie? I talked about this last semester. Finding Nemo, all the krill, right? They see the sperm whale or something, or some whale, and they see it and they say, swim away, and they all take off. That's what your sperm do when fibrinolysin is released. All right, bulbourethral glands are going to protect the sperm by secreting an alkaline mucousy substance before ejaculation even occurs. So this is the pre-secretion, and it is going to protect the sperm from the acidic nature of urine residue, because urine can be pretty acidic, and it just kind of cleans it out for you. All right, erection and ejaculation. And this is where we answer the question, what part of the ANS is responsible for what part of the reproductive stimuli. All right, so erection is going to be point parasympathetic, point parasympathetic. Ejaculation is shoot sympathetic. So that helps you remember which part of the ANS is responsible for what. Remember that we don't want erection to occur in the sympathetic nervous system, because that would be really uncomfortable to have anxiety or fear and be running away from something with an erection, right? And so we want erection to stay in the parasympathetic section. Now, what is going to stimulate that? Sexual stimulation is going to cause a release of nitric oxide. Nitric oxide relaxes the smooth muscle in the arterial wall. The sinuses are going to open, blood will flood in, and that is going to cause vascular spaces to engorge, which is going to cause the penis to enlarge and become rigid. How is an erection maintained? When that rigidity occurs over here, then you are going to block, look at these outflow veins when the penis is flaccid. Look at the outflow veins, nice and big, and blood can come and go as it pleases. Look at the outflow veins during an erection. These outflow veins are going to be very small. Why? Because they're compressed. they are constricting the outflow veins. And so therefore the blood cannot escape until relaxation occurs. And so that is how an erection is maintained. Now, this nitric oxide is utilized in medications like Viagra. Nitric oxide was used as medications for hypertension, high blood pressure, so that it can open up the vasculature. So I had a student, actually a really young girl, that had pulmonary hypertension, very dangerous. The vessels in the lungs are going to be such high blood pressure that you can't get enough blood flow to the lungs, and therefore you don't have oxygen being diffused, all right, and into the blood. And so she takes Viagra, and she is not taking it for sexual function, but because that's what it does. It is going to relax the smooth muscle of arterioles and allow blood flow to get where it needs to go. So early, when nitric oxide was being used just for hypertension, there's this, all of a sudden, this side effect that these guys are like, what the heck? I like have low blood pressure and this. And so that side effect, they turn this drug into, with higher amounts of this, of the nitric oxide, then you can help erectile dysfunction. All right, ejaculation is going to be part of the sympathetic nervous system, and you have spinal cord nerves, L1 and L2, and the pudendal nerve, which is in the sacral segments, and then the superficial perineal muscle contraction, and all of that is going to trigger ejaculation, which includes all of the orgasm sensations that come with that. Okay, females. All right, we're a little bit more complicated because we got to carry a baby. And so there's lots of other things that go on besides just egg making. All right, so the job is to make the egg. But then after we do that, if it's fertilized, then we are going to receive, retain, and nourish a fertilized ovum and grow a baby. And this is all dependent on mostly estrogens and progesterones that are secreted by the female reproductive system. Our female gonads are the ovaries, and then we have accessory ducts and organs, and that is going to be the uterine tube, the uterus, the vaginal, and the vulva. We are going to carry out a similar pathway of growing eggs, but I want to go here first. So, ladies, we make all of our eggs before we are even born. Okay, we make all of our eggs before we are even born. And they're already in place. And so once again, this is why as girls, we're better multitaskers. We're not busy every day trying to make eggs like the guys are making sperm every day. So it's just the way it is. All right, so we've got this lifetime supply, but as we age, even at birth, we go through a process called atresia. And atresia is going to decrease the number of eggs over time significantly. So immature and dormant for 10 to 14 years, these primordial eggs are going to become active at puberty. And at that time, at puberty, we're all the way down to 400,000. And then more degeneration over time is going to cause us, if you look down here, here's birth, and then puberty, you have 23% left. And then at age 30, 180,000, 12% left. And then by the time you're 40, you have only 3% of the eggs left, as you did when you were born. So atresia is a real thing, and menopause then stops estrogen production, and there is no way that we can develop any more of those primordial eggs after menopause because we have no estrogen. Okay, so these eggs are going to be released in a cycle every single month, 28 days from puberty until menopause. Okay, so the process of growing an egg is going to be oogenesis, and it is dependent on follicle cell maturation, and that is due to what we call ovarian follicles. The ovarian follicles are going to be the little cellular houses that our eggs live in. And the ovarian follicles are going to be in the cortex, or the outside area of the ovary. And then the medulla is going to have all of our blood vessels, right? Blood vessels and tissue. So it's going to be this center area right here. That's the medulla. All right. So we have these sac-like structures in the cortex. Those are the follicle cells, and they contain the immature oocytes. And depending on how many layers of follicle cells surround it, that's how old our ovum is. It determines the maturity level. These follicle cells are going to secrete estrogen. And this is the location where our first meiotic division occurs. Folliculogenesis has about 4 stages of follicular cell growth. And so we have primordial, so I'll write these in: primordial. Then we have the primary folliculi, and then we have the secondary, and then we have the tertiary, which is also called the Graafian. And those 4 stages are going to, these are the same, so 4. These 4 stages are going to determine the maturity level of the ovum. And as these cells, as these follicle cells mature, they provide nourishment and hormones to the developing egg. All right, so let's look at oogenesis, okay? We start out like the sperm, but our stem cell is called oogonium instead of spermatogonium. And we divide by mitosis, okay? So we have 46, and we end up with 46 at 46 because that is mitosis. Now, this one stays home to take care of the family business. This one is going to become a primary oocyte. All right, so the primary oocyte begins meiosis 1, okay? Begins it, but it doesn't finish it until puberty, okay? So meiotic division at puberty. FSH starts to be secreted, and it stimulates the complete division into a secondary oocyte once a month. Okay, let me explain this a little bit better. At puberty, once a month, a few of these primary oocytes within their follicle cells are going to be released. And those are the ones that are going to complete meiosis 1. Then the next month, another handful of primary oocytes will be released, and they complete meiosis 1. And so they are only completing the first meiotic division if they are released each month as a primordial follicle, and they can divide into a primary oocyte, okay? Now, when it is complete and we get this first meiotic division, look at what happens. We've got this secondary oocyte, and then we have what should be another secondary oocyte, but it's not. It's tiny with no cytoplasm. This secondary oocyte stole all the cytoplasm and left nothing for the other sister cell. This is called a polar body, and it will be non-viable. Non-viable, cannot become an egg. Then the secondary oocyte is going to start meiosis 2, but again, it starts it and it does not complete it until and if fertilization occurs. The only time a secondary oocyte will complete its second mitotic division is if fertilization occurs. Therefore, most of our ovulated eggs will never complete meiosis 2. Mine completed it 4 times. I have 4 kids, maybe more if I had some miscarriages, you never know. But that is where meiosis 2 is completed. And this, if it is completed, it results in a zygote. And so we have the zygote. And why is it a zygote? Because the sperm penetrated, and now I have 46 chromosomes, 23 from the egg, 23 from the sperm. And then look, it stole all the cytoplasm again. So I have another polar body, right? Another polar body here that is non-viable. This first polar body divided and gave me 2 polar bodies. And then I have this polar body. So when all is said and done, at the end of oogenesis, you have 1 viable ovum that has been fertilized. Okay, so 1 viable ovum and 3 polar bodies that are non-viable and never can become an egg because they don't have enough cytoplasm. Why did this egg steal all the cytoplasm from all of its sister eggs? And the answer to that is, we're trying to make a new person here. And what is the sperm contributing to that? This guy comes in and all he gives is his genes. He comes in bare-chested wearing a pair of blue jeans and that's all. And it says, okay, I'm here. And that's it. So because the sperm got rid of all of its cytoplasm, all of it, so that it could swim faster and be first in line to fertilize this egg. And so we've got the sperm that gives us 23 chromosomes, and that's it. Therefore, the egg has to supply endoplasmic reticulum, Golgi apparatus, lysosomes, enzymes, proteins, peroxisomes, ribosomes, all of the things that are necessary to carry out normal cellular function. And this cellular function is excessively important because it will divide very quickly into an embryo. Okay. All right. So zygote, fertilized egg, polar body, non-viable ovum. All right. Covered that. Okay. Now we're going to talk about the ovarian cycle. This includes both the follicular cycle and the ovarian cycle, but there are going to be two phases to the ovarian cycle. Now, this is a little bit more information than what I gave last semester in anatomy because we are in physiology. So let's look at this. We are going to go through the ovarian cycle 2 phases. Okay, this first slide is going to give us 1, 2, 3, 4, 5 steps in the follicular phase. We call it the follicular phase because this is where the egg is surrounded by the follicle cells. So the primordial follicles, okay, primordial follicles are going to, this is number 1, they sit in an egg nest in the ovary. And at puberty, primordial follicles are released each month to continue development. So a handful of them are released to continue development. Yay, they've been chosen. They are going to differentiate and grow into primary follicles. Primary follicles are going to have more layers of cells surrounding the egg, more layers of cells. These cells are then called granulosa cells and thecal cells, and they are going to, here's my granulosa cells, which have replaced the name follicular cell, but we still call it the follicle. And then we also have thecal cells on the outside of it, and those are going to secrete estrogens. Okay, estrogens. Estrogen is going to allow the egg that is inside this follicle to continue to grow and develop. Then we hit our secondary follicle, and we know that it is the secondary follicle because the secondary follicle starts to secrete a little bit of fluid, all right? So that the follicle cells start to secrete a little bit of fluid, and that fluid tells us, okay, we're really maturing here. That pocket of fluid gets bigger and bigger, and when you look at the tertiary ovarian follicle, right here, you can see that the house that the egg lives in now has a swimming pool. Look at this antrum. The antrum is going to be an area, here's antrum, an area that is full of follicular fluid, okay? So this is a tertiary follicle or Graafian follicle. It's important to know the age of the ovum, and it's the follicular cells and this antrum of fluid that can tell us that it is the most mature it can become before ovulation occurs. Because when you do in vitro fertilization, they harvest eggs from an ovary from the female, and they have to be able to detect the most viable ovum. Those are the ones that are the most mature. So they look for this tertiary ovarian follicle, and those are the ones that they harvest. All right. So what happens is this ovum, it actually, when it's mature and ready for ovulation, it breaks through these thecal cells and it starts to go swimming in its swimming pool. So it becomes loose and free in this follicular fluid. And at that point, the whole follicle is going to push against the wall of the ovary, and the ovum is pushed out in ovulation, which is number 5. This is a cool picture. Here's the ovarian wall. Here is the swimming pool, all the fluid that the egg was in, and that is pushed out of the ovarian wall, and it is going to be ovulated. All right, but now, and that occurs on day 14 of the 28-day cycle. Okay, so this is a 28-day cycle, and on day 14, ovulation occurs. Now we go to the next phase. And the next phase is the luteal phase. The reason why we call it the luteal phase is because we'll follow the egg later, but we're going to stay in the ovary. So these follicular cells, after ovulation has occurred, they are going to differentiate into cells that make up what we call the corpus luteum. Okay, so the corpus luteum is a yellow structure. That's what luteum means, is yellow, a yellow structure. And its importance is to secrete progesterone and estrogen. And the reason why is because progesterone is a hormone that goes through the bloodstream and targets the uterine wall and tells the uterine wall, hey, we got an egg coming, fertilization is possible. So you need to build up the endometrium, make it nice and full of nutrition and thick, so that if we get implantation, we can maintain that embryo. And if fertilization does occur, it will be implanted in the uterine wall, and there's no placenta. So what nourishes the developing embryo for the first 3 months? The corpus luteum secreting progesterone, telling the uterine wall, hey, make sure that you are nice and nutrient full and can maintain this embryo until the placenta can take over for 3 months. So when you're looking at infertility, one of the things that they look at, if you often are going to miscarry within the first 3 months, which is most common, there's not a lot of protection yet. There's no placenta yet. And so there's a lot of things that can go wrong. But at the same time, that first 3 months, you're developing every structure in the body. And then the rest of the time, you're just making those structures bigger. So it's really kind of impressive what we do in those first 3 months and why we girls are so exhausted and sick in those first 3 months. Okay, so that is the importance of the corpus luteum. They can test progesterone levels. And if progesterone levels are low and miscarriage occurs often in the first trimester, they can give you progesterone supplementation to try and maintain that pregnancy in the first 3 months. But let's say that the fertilization does not happen. Okay, fertilization does not occur. And so the corpus luteum after 12 days says, oh, didn't happen again. And so it will turn into the corpus albicans. Albicans means white. And the albicans is going to secrete inhibin. So it does secrete a hormone that shuts down FSH and says, okay, it didn't happen. So but what this also is scar tissue. And so scar tissue scars the ovary. And so someone like me who has 40 plus years of ovulation, am going to have a very scarred and pitted ovarian wall because of all the corpus albicans every single month for every single year that ovulation occurred. And if you have a 16-year-old and you look at her ovary, it's going to be nice and smooth with very few scars. And so you can determine the age of an ovary based on the scarring. All right, so when we look at the ovarian cycle here, we see the follicular cells. So this is going to be that tertiary ovarian follicle that continues to develop. You can see the swimming pool here. The egg is going to push through, swim in its swimming pool, and that's when we know it is ready for ovulation. So let's look at the hormones that are increasing during this time. Ovarian hormones, you're going to have estrogens. Why? Because estrogens are going to be supporting the growth and maturation of the developing ovum. And that's going to be being secreted by those follicular cells, or what we call the granulosa cells. And so estrogen is going to be increasing during the development of that ovulation, or until ovulation. Then when ovulation occurs, we're no longer growing an ovum, and so it is going to have a quick fall after day 14. Okay, quick fall, and then as the corpus luteum takes over, then the corpus luteum will increase the estrogen somewhat as well. So the estrogen here, all the way to this point, is going to be coming from the follicular cells and the granulosa cells. But here it will be coming from the corpus luteum, which are still follicular cells. They are just going to be different in that they form different types of cells that are secreting both estrogen and progesterone. So look at my progesterone levels after ovulation. Okay, so progesterone is in black. Look at those levels after ovulation. This is talking to the uterus and saying, hey, uterus, thicken up, thicken up, thicken up, because seriously, we might have a pregnancy here. And then after 12 days, when we decide we didn't get a pregnancy, then the progesterone starts to fall. And that's when the uterine wall starts to slough off in menstruation. All right, inhibin also is going to be secreted at the time that we realize, hey, fertilization did not occur, and so let's decrease the FSH that's going on in the brain as well. So let's look at that FSH. Look at what happens when inhibin here starts to increase. Look at what happens to FSH. It is going to decrease. Okay, because inhibin inhibits FSH. All right, so this is going to be in the brain. So LH is our ovulation hormone. Look at where it peaks, day 14. LH stimulates ovulation to occur. So it peaks on day 14 and then drops significantly. All right, we have, oh, sorry, that's in pink. Look at the big peak up and down, right? And so we have LH that peaks right at day 14 and then drops right when ovulation occurs. All right, and so this in green is going to be the gonadotropin releasing hormone that we get from the hypothalamus, and that pulses on a daily basis, and it is going to change over the 28-day period to stimulate FSH and LH. So you can see the rising amount of it rising, and that is going to stimulate LH and FSH, and then LH and FSH are also going to stimulate estrogen. Okay. All right. So those are the levels of hormones that are going on during the month, and we get, after menstruation occurs, we get kind of an alleviation of these hormones. So let's look at the uterus, and then we'll talk about menstruation. All right, so perimetrium is the outside of the uterus, and myometrium is going to be the muscle layer right here, and endometrium is going to be the inner layer. Okay, so 3 different layers. And the myometrium is going to be smooth muscle, and that is what is responsible for labor contraction, for labor and delivery. It is amazing what this myometrium can do, because your uterus right now, if you're not pregnant, is the size of an upside down pear, size and shape, and it can grow exponentially. So this muscle can stretch, 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 and grow to house a full size preterm baby, right? And then not only can it stretch, but then the contractions that it makes are so significant and so hard that it can actually expel the baby out of a very small space. All right. And so this muscle has a lot of power, even though it is so thin. In fact, I can remember during my labor, as I was having a very, very hard contraction, that your abdominal wall literally takes the shape of the baby, because it is contracting so hard that it is squishing around the curves of the baby. And I can feel like my baby's bum because of the hard contractions. It was just so crazy. It makes that abdominal wall as hard as a rock. It just makes it so hard during that contraction. Okay, now endometrium. Endometrium is going to be where the fertilized egg implants. So one of your questions is, where does fertilization occur? And that is going to be in the uterine tube. So these poor sperm, no wonder they're not offering much when they get there, because they have to travel through the vaginal canal, up the cervix, through the uterine cavity, and into the uterine tube. Okay, so that's where fertilization occurs. And so the egg is traveling from the ovary around and through to the uterus. All right, so the uterus is going to be now preparing for pregnancy, for a possible pregnancy. It has a basilar layer, and that basilar layer is the permanent layer, and it's responsible for forming a new functional layer every single month. The functional layer is going to undergo the cyclic changes in response to progesterone. And it is going to build, and it is going to be very, very thick with nutrients. It is going to be very high in blood content and vessels. And then we are going to decide that pregnancy did not occur. Therefore, those cells in that functional layer will be broken down, and that is due to the lysosomes that are in each of the cells. And when we decide that we don't need these cells anymore, then they are going to be destroyed by apoptosis, and that is going to cause shedding of a lot of layers. The layer thickens in preparation for pregnancy and then sheds if implantation does not occur. Here is a diagram of that menstrual cycle, and there are 3 phases. The first phase is the menstrual phase. This, and I have this right here, so I'm going to describe it, and then we're going to look at the steps. Okay, so we have the menstrual phase. The menstrual phase is day 1 through about 7, and this is the loss of the functional layer. So destruction of the functional layer, which means, ladies, this is the day you start your period. So we're going to start our cycle, our 28-day cycle, on the day we start our period, because that is a definitive day. I started my period today. This is day 1, and we call that the menstrual phase. The menstrual phase during this day, it's really days 1 through 5, but you can have the loss of that endometrium called menses. The shedding takes 1 to 7 days, sometimes more. Okay, so it's the shedding that is that 7 days. During this time, FSH is increasing because we are starting to develop new ovarian follicles. We are starting to develop new eggs because we're like, oh, we didn't get pregnant, and so let's make new eggs. And so FSH increases during this phase. The second phase is the proliferative phase, and this is where we start building up that functional layer once again. We start to build up the tissue that is going to provide the nutrients for a fertilized egg. So we are preparing for, I like to say, we're preparing for pro-life, meaning implantation. Okay, so it just helps you remember the name of this phase. Proliferative means pro-life, we're preparing for life. Okay, so that during that time, this is day 6 through 14, endometrium is rebuilding itself and it ends at ovulation. FSH, again, still is at a level where it's stimulating the growth of the ovarian follicle and the ovary. Estrogen is secreted by the ovaries, and it's going to mature the ovum and stimulate growth of blood vessels in the endometrial wall, and that is going to stimulate growth of the functional layer. LH is also increasing slowly, but remember it peaks on day 14 for ovulation, which is going to be at the end of the proliferative phase. Okay, the last phase is the secretory phase. So what are we secreting and where is it coming from? Remember, this is the same phase as the corpus luteum is secreting progesterone. So why is it the secretory phase? Because the luteal phase of the ovarian cycle is secreting progesterone, and that is causing the uterus lining to increase in its secretion of nutrients, blood, all the tissue that we need to support a growing zygote if it gets implanted. Okay, and so that will end at day 28 when we've decided that it didn't occur, and so we decrease the amount of progesterone. And so secretory, we increase progesterone until 12 days after, when we decide fertilization did not happen, and then the progesterone will decrease at that time, and that will begin to slough off, which begins the whole cycle again. And of course, LH decreases because we are not ovulating at that time. So this secretory phase is the whole last half of the cycle. And that is because of the corpus luteum secreting that progesterone and estrogen. Okay, so that is the menstrual cycle. Now, not all menstrual cycles are going to be the same. 28 days is going to be an average, and it could be a day before, 2 days after. So my 18-year-old, she can go 3 months without a period, a lot of times exercise. If you're, very, very active, it can change it. Nutrition can change it. Stress can change it. There's a lot of things that can change it. Typically, though, after you have your first baby, if you have a baby, it usually is going to make it a little bit more stable, where you have a relatively stable cycle every 28 days, more or less. Okay, now what happens after? Okay, let me make sure I've covered all this. We did mitosis versus meiosis, and we did the spermatogenesis and the oogenesis. Okay, so remember that all of this is happening for the sperm during one, because we're making so many sperm, you get 4 viable sperm. But in oogenesis, a lot of our meiosis is going to be stalled, 1 till puberty, meiosis 1, and then 2, meiosis 2 at fertilization. And so we get a stalling of those processes. And then with oogenesis, remember, we only get 1 viable ovum and we get 3 polar bodies, where the sperm, we get 4 viable sperm. Okay, then let's look at, we talked about the follicle cells. Remember, they house the ovum. They're going to secrete estrogen, and then the follicle cells turn into the corpus luteum and secrete progesterone. The zygote is a fertilized egg. The gamete is the ovum for the female and the sperm for the male. And remember, the gamete is haploid, only 23 chromosomes. Describe the function of the corpus luteum and corpus albicans, and what hormones do they secrete. We just talked about the corpus luteum secreting progesterone, and then the corpus albicans, which is the white fibrous structure that secretes inhibin, and that is going to inhibit the FSH. All right, and then describe the phases of the menstrual cycle. We just did that. Describe the constituents of semen and the function of each. That's kind of misplaced in here, but we already did that. We talked about semen. We talked about the prostaglandins. We talked about fructose. We talked about seminal plasmin. We talked about profibrinolysin, and we talked about all the functions that those have. So make sure you review those slides. Let's see. I thought that was in there, and then I didn't see it, but there it is. It's hidden in the female bullet points. Let's see. Then we have, what are the meiotic stages of the ovum? Where does each phase occur? And so in meiosis 1, remember, that happens in the follicle cell. That happens in the follicle. So meiosis 1, if it is completed because it's been chosen, then estrogen will push it through to, meiosis 1, it becomes a secondary follicle. But remember, that secondary follicle is only going to complete meiosis 2 if fertilization occurs. So where does meiosis 2 take place? Where does fertilization take place? And the answer to that is going to be the uterine tubes. That's where it is going to take place, if it takes place at all. All right, then we have what is the function of FSH and LH in the ovarian cycle? And we saw that it's going to stimulate the secretion of estrogen, the growth of the ovum and follicle cells, and then LH is ovulation. Where does fertilization occur? The uterine tubes. Where does implantation occur? And that is going to be in the endometrium, the functional layer. So that's what we're going to talk about now. And we are going to see that fertilization takes place, here it is, in the uterine tube. Sperm are initially incapable of fertilization because they haven't gone through capacitation yet. Capacitation allows them to have 2 capabilities, right? Capacitation capable of what? All right, 1, it allows them to be able to swim. They can actually use their flagella to swim. They are kept from swimming until they are close to the cervix in the vaginal canal. 2, it is going to activate the acrosome. And remember, that was the little helmet, and that helmet is full of those digestive enzymes that can digest the wall of the ovum. Okay, there's so many different things that are going on during this in human development, like if you take a human development class, it's almost overwhelming, all the things that have to happen perfectly in order for fertilization to occur. So you can see here that the approach of the sperm aided by enzymes on its surface. So this capacitation, not only are these enzymes there in order to help them get through the egg, but they have this mass of granulosa cells that are surrounding the egg, and they have to push through that. So it weaves its way past those granulosa cells of the corona radiata, and corona means crown. So it's this little princess crown around our egg. Our eggs are such princesses, and they are protected, and only the most valiant of the sperm who are strong and healthy and can push through my crown can get to the wall of the ovum. All right, so this diagram is going to show where fertilization occurs. These sperm, once again, have a long way to go, and they are going to get all the way, not just right here. They have to get all the way to I think it's the antrum of the uterine tube for fertilization to occur. So big, long journey, and not all of them are going to make it. And so that's why there's so many of them, millions of them in one ejaculation. At ovulation, oocytes enter the uterine tube. Cilia, so the fimbriae are these little finger-like projections. So here's my ovum, and the fimbriae are literally moving the fluid and sucking the egg into it. If the egg does not make it into the uterine tube and it makes it outside of it, we call that an ectopic pregnancy. And it is usually non-viable. An ectopic pregnancy is usually non-viable. That egg can still get fertilized, but if it is not in the uterine tube and go to the uterus where it can be protected and housed appropriately, it usually does not survive. Sometimes, rare occasions, it will continue to develop, but it can never be delivered because there's nowhere for it to go, because there's no outlet. And so it is usually aborted early in the pregnancy. All right, sperm must meet the ovum during the 4 days, right? The 4 days that the egg is in the uterine tube. All right, which means, you guys, that if you're using rhythm method to not get pregnant, you have, 3 to 4 days before ovulation and 3 to 4 days after ovulation that you can be at risk for getting pregnant. All right, so when this occurs and fertilization occurs, we have our first cell of this new individual, and that is a zygote. 46 chromosomes, 23 from mom, 23 from dad. We get what is called cleavage. This divides within this cell, the zona pellucida right here, keeps it nice and tightly packed in. We get division of 4 cells. Those 4 cells turn into many cells. This is called a morula. And once these this bundle of cells is, let's see, how do I explain this? This bundle of cells will pack itself into one little inner cell mass. And you can see the inner cell mass right here. And then this zona pellucida, the cells of the zona pellucida, turn into what we call the trophoblast. And the trophoblast is going to be the cells that surround that inner cell mass. And then you have a blastocele, which is just, cele means hernia, actually. And it is just an invagination with fluid in it. This is our blastocyst, where you have an inner cell mass with the blastocele surrounded by trophoblast cells. That is what enters the uterus, and that is what implants in the uterine wall. So let's look at that. Sperm capacitation, deposited sperm, they can't fertilize the oocyte because capacitation is required. So how do we allow those enzymes to be activated? Well, we've got to remove the seal on them. There's a seal that has them all sealed up and tight in a box, we've got packaging tape on it. And that packaging tape is going to be carbohydrates and cholesterol. So we're going to remove the cholesterol and carbohydrate on the acrosome cap. And now those enzymes are accessible. And that is going to allow penetration of the zona pellucida, which will eventually turn into the trophoblast. All right. Then we have fertilization, and that is when the sperm and the ovum are going to migrate to the center of the ovum, and they are going to merge together. So the nucleus with the head of the sperm are going to merge together, and we are going to merge the genomes together. All right, so we bind the membrane to the oocyte sperm binding receptors. Yep, there are sperm binding receptors. Fusion occurs, and the sperm contents will enter. Now, how do we make it so not more than one sperm enters? And check it out, the whole sperm doesn't even enter. Only the genetic region, which is the head, right? Just the genetic region that has those 23 chromosomes. That's all that's allowed in. And so once this occurs, then we have a blocking mechanism where the receptors are going to be shed. No more sperm receptors. We get rid of them immediately. Calcium levels in the oocyte they're going to rise, and it triggers this reaction, and the zona pellucida hardens. And so now sperm binding receptors are not even available anymore. And so you can see in this diagram that we get rid of all those sperm receptors. And so only one sperm is going to penetrate. When it attaches to those receptors, we get an immediate clamping off of the rest of those receptors, and the zona pellucida is going to harden. So no other sperm can get in, and we don't get polyspermy. Okay, implantation occurs 6 to 7 days after fertilization, and the trophoblast, or the outer layer of cells right here, are going to be responsible for that. They secrete enzymes that are going to digest the endometrial wall. And so we get rid of that barrier, and it is going to implant into the nice nutrition-rich, blood-rich environment of the functional endometrial layer. Okay, so it secretes the enzymes that digest the endometrium, and that endometrium will now provide nourishment from how much blood vessels are there. And after you menstruate, you realize it's a lot of blood there, and blood is full of nutrients, right? And so that is what is providing the nutrients to this blastocyst. So the blastocyst is going to bind and implant, and the trophoblast is going to be what penetrates it. The trophoblast cells will eventually form the placenta. Okay, it will eventually form the placenta. So the non-embryo part of this whole structure. Okay, non-embryonic part. And then the inner cell mass is what will create the embryonic cells. And we have 3 different types that will create layers, and all of those will eventually differentiate into all the different parts of the developing embryo. All right, so that's as far as we'll go on that. And then now just the baby has grown, and it's been 9 months, and wow, that was fast, but not really. And the beginning of parturition occurs, and that is the cervix dilation. Now we have the reason for parturition and why, what triggers, sorry, my words are just getting all jumbled. What triggers labor? That's the question. And the answer to that is kind of unknown. What actually triggers it? The head that is being pushed against the cervix is what creates the continuation of labor, and then eventually delivery. But what is the moment that starts this whole process? And there are some speculations that it's hormones that are being produced from the fetus itself, from the placenta, from the amniotic fluid, lots of different things that are suggested. All right, so beginning of parturition, the cervix dilates and we get labor, which is uterine contractions. Then parturition, this is where the baby's head is going to wedge the cervix open, okay? And the baby should be born head first. If they are not, it can be dangerous, and that is called breech. When a baby is feet first, that is breech. And then after the baby is born, so the baby is born, then you have to birth the afterbirth, and that is going to be the placenta. So the placenta rips away literally from the wall of the uterus, and this causes bleeding. And so this can be dangerous if the uterus does not contract after delivery. So delivery occurs, the placenta is literally a sack of blood. In fact, I told him after I had my babies, I want to see that placenta. I want to see it. And so they showed it to me, and the cord is cut, baby's out, but it is literally a sack of blood. And it has really, really good proteins in it, these placental proteins. And you know that they harvest placentas, and they take this placental protein and they harvest the placental protein, and guess where they use it? For burn victims, because this placental protein is so good at helping skin to repair itself that they use this placental protein on the skin of burn victims to help them repair the skin that has been damaged. I used to work for New Skin years ago when I was in college, and we have products that actually have placental protein extract in it, which freaked people out a little bit. But it's the protein that's extracted, right? And it's done medical grade extraction, and just like they do for burn victims. And so we put that protein in this, only a few of the skincare products. It used to be in all of them, but people would freak out over it. It's not like someone's placenta is in the product. It's just the protein that we extracted out of it. And so that's in a couple of the products still, I believe to this day. And you can purchase those from New Skin. What was it called? HP human placental extract, and they called it was like an abbreviation of it. Anyway, all right. So if you have scarring or anything like that, might be something to look into because it's really good for your skin. Okay, so now when the placenta is delivered, it just ripped away from the uterus. So the uterus will continue to contract and contract pretty hard because it wants to constrict the vessels that have been damaged so that you don't bleed. And so the constriction and the contraction of that uterus over time is going to do two things for you. One, it's going to decrease bleeding, which actually bleeding occurs for a month or so or more after delivery. And so you're literally wearing diapers after you deliver a baby. I know everybody who hasn't had a baby is like, seriously, what? And so you bleed quite a bit afterwards. But the other thing it does is as the uterus contracts, it is stimulating the breasts to secrete milk. All right. And so this is all based on oxytocin. Oxytocin is responsible for contraction of the uterus. Do I have that? I do. All right. So what happens is oxytocin is secreted from the posterior pituitary, and that goes to the wall, the smooth muscle of the uterus, and the contractions increase in how strong they are and how close they are together. And then the pressure of the fetus during those contractions hits against the cervix, and that is going to go back to the brain and say, okay, we push the head of the fetus against the cervix by contracting, and so more oxytocin is secreted. And once again, it strengthens the uterine contractions, causes them to be harder and closer together, and the fetus's head again pushes against the cervix. And so that sends a message again to the brain to secrete more oxytocin. And so this is a positive feedback system where oxytocin is exaggerated in its secretion because of the pressure of the fetus against the cervix every time the contraction occurs. All right. And so weak uterine contractions can be the trigger, right, for sending information to the brain to start labor and delivery, but we're unsure if that's what it is. Suggest signals come from the fetus. Once the contractions are hard enough and closest together, then parturition occurs. All right, lactation is after birth, then changes are made in the secretion of prolactin and oxytocin. All right, so prolactin stimulates the synthesis of milk, so it makes the milk in the glands. So prolactin comes from the anterior pituitary and is going to target the glands in the breast. Oxytocin is what is stimulated for milk ejection reflex. So this is the milk letdown reflex. If any of you have nursed before, it is this pins and needles feeling of milk being released into the lactiferous ducts or the milk ducts, which are delivering milk to the nipple. It is just not a pleasant feeling, but you kind of get used to it. All right, so we need both prolactin for the synthesis and oxytocin for the release of it. The first type of milk that is secreted is colostrum, the first few days after birth, and it is protein packed. It is very, very nutrition packed as far as proteins go and necessary for that fetus in the first few days. Okay. Later milk is going to have lots and lots of nutrients, growth factors, hormones, and antibodies. Antibodies, it's going to be that passive innate immunity that is going to allow mom's antibodies to be passed to the baby so that it can be protected from disease while it's developing its own immune system. All right, so you've got these milk secreting glands, and then you have a duct system, which makes it an exocrine gland, and that is going to go to the nipple, and it is going to be triggered by the sound of a baby crying, the suckling of a baby on the nipple, and all of that is going to cause the brain to release oxytocin, and oxytocin is what causes the milk letdown reflex. Okay. All right, that is it, you guys. Hope you enjoyed the chapter. Hope you enjoyed all the chapters. I know it's a lot of information, but it is amazing. And I hope that you feel like you've been amazed by yourself this semester. This is the last actual chapter, and I'll send some more recordings for our reviews. Okay. All right. I will see you guys on Tuesday.